Welcome everybody, and thank you for joining. I'm going to start by giving a very brief overview of amyloidosis, which is a condition caused by a buildup of abnormal proteins. These proteins change shape, they misfold, and they clump together. And these clumps form fibrils, which deposit in organs. And as these fibrils build up, they can cause damage to the organs, and some of the function of the organ may not work as well as it should. Often the symptoms of amyloidosis are not specific, and the diagnosis can be quite challenging to make. It can mimic lots of other conditions, and as doctors, we need to think about amyloidosis. Two types of amyloidosis predominantly. There are actually 9 types that affect the heart, but for the purposes of tonight, there are 2 common types of amyloidosis that affect the heart. The first is AL amyloidosis, which Mark alluded to. In AL amyloidosis, there are abnormal plasma cells in the bone marrow, and these secrete light chains that misfold and aggregate. We're going to focus more on TTR or transthyretin amyloid. In ATTR, the problem is the liver. Transthyretin is a protein that normally transports thyroxine and vitamin A around the body. And if it misfolds, it can aggregate and collect predominantly in the heart. So there are 2 subtypes of transthyretin amyloidosis. There's a subtype called wild type, which is predominantly a cardiomyopathy. Now, this typically affects older males. We don't really understand why that's the case, but it is a feature, and that on its own should alert a doctor to thinking about amyloidosis. The less common form is the hereditary form. This can present with a cardiomyopathy, but also a neuropathy. When we talk about inherited diseases, there are different patterns of how inherited diseases can be passed on. An ATTR amyloidosis is what we call an autosomal dominant condition. It's passed on from generation to generation and doesn't have a particular male or female predisposition. So overall, hereditary amyloidosis is considered to be a rare disease. But genetics follows geography, and there are common hotspots around the world. And there are some places where specific genetic variants are much more common in the population. Carrying a genetic variant doesn't mean that you have the condition, but it increases your risk of developing the condition. In the west of Scotland, we share a lot of ancestry with Ireland, and in Donegal, there's a particular hereditary form of amyloidosis that is more prevalent in the population. Traditionally, amyloidosis was diagnosed with a heart biopsy when it affected the heart. Now you see here the procedure involves putting a catheter into the vein in the neck and passing a pronged instrument down inside the heart. It's not particularly nice procedure to do, and it's not particularly a nice procedure to have done. And it's something that we don't like to do unless it's absolutely necessary. On the bottom of the slide, you see the classical pictures of amyloidosis, and it has this classical staining under the microscope. So for many years, this was really an imperative part of making the diagnosis of amyloidosis. So I said amyloidosis was rare. Whilst the genetic type may be rare, over the last 10 years, we've seen a real growth in the number of patients diagnosed with wild-type amyloidosis and an increase in the hereditary types. And this is data from the National Amyloidosis Centre in London. And you'll see there's a real inflection around 2010 when the numbers of patients diagnosed with this really takes off. And that follows improvements in cardiac imaging, and it follows improvements in how we see the heart. And I'm just going to take you really on a journey that many of you will have been on to explain how we now try to make a diagnosis and why I would hope we're better at recognizing and making a diagnosis. This is just for general education, but I think one of the first patients I met with amyloidosis actually lived in the west coast of Scotland and ended up in Edinburgh Royal Infirmary. And as a junior doctor, I was quite interested in what could be wrong with this patient. He'd been a conundrum to his local doctors for 2 or 3 years. He was very tired. He's been lightheaded. He'd been diagnosed with heart failure, but the standard treatment wasn't working. He had really swollen legs and really low blood pressure. And it had been difficult to help with medication because his blood pressure was too low to increase the doses. He'd come to Edinburgh to have a pacemaker. And despite his pacemaker, he didn't feel too much, that it had made too much difference to his ability to go out and walk and climb in the hills. And after much investigation and a heart biopsy, this chap was found to have amyloidosis. And I think really since then, I became quite interested in cardiomyopathy and heart muscle diseases. The patients were slightly different from many of our patients in the cardiology wards who smoked and had heart attacks. So it was a welcome change and interesting diagnostically as well. So this is an echocardiogram from one of my patients with amyloidosis. This is an ultrasound scan, which is taken at the bedside with some jelly on the chest. It shows what we call a 4-chamber view of the heart. You can see in the main part of the picture is the left ventricle. This is the main pumping chamber of the heart. What we see is that the heart muscle is thickened. And very often this is the first change that might be noted when you see a cardiologist, that there's thickening of the heart muscle. Now, certainly in the west of Scotland, the commonest cause of a thickened heart muscle is high blood pressure or being overweight. But we need to think differently when somebody doesn't have those features. Many patients come with a diagnosis of, could this be heart failure? Heart failure on its own is not a particularly nice term, and it is very much an umbrella term. It tells us that there's a problem with the heart as a pump, but it doesn't really tell us why there's a problem. The term cardiomyopathy is a little more specific in that it describes heart muscle disease. And ATTR is an even more specific diagnosis, where the cardiomyopathy is due to amyloid deposition in the heart. This was a slide I showed to some of our cardiac specialist nurses. I was teaching them last week. We see many, many, many patients with breathlessness, with ankle swelling, with dizziness. But there are certain things that I call red flags that should make us think about amyloidosis. And I really think it's our job collectively to help educate people that can look after us all for the future. So you may have experienced some of these symptoms: numbness, bloating, gut symptoms. There are certain markers in the blood tests that should alert us to amyloidosis being a possible diagnosis. And there are certain changes on the ECG and an echocardiogram. The echocardiogram I showed you was a fairly basic echocardiogram, what we call a two-dimensional echocardiogram. But as computer technologies improved over the last decade, so has cardiac imaging. And we can now see things on imaging that we could not visualize 10, 20 years ago. And we can look at that heart scan in a lot more detail. And we can measure not just the size and the thickness of the heart, but we can measure the strain or the contractility of how that muscle is moving. An amyloid gives a very classical appearance. We describe it as a cherry on the top. So the top of the heart contracts well, but the base of the heart is stiffer. And that pattern we're trying to train our cardiac sonographers to pick up and to recognize. Cardiac MRI is really responsible for that inflection that you saw on the graph. We're fortunate in the UK that the National Amyloidosis Centre in London has led a phenomenal amount of work and research into this condition. And cardiac MRI was adopted in the UK fairly well, and in Scotland there are all the major centres has cardiac MRI available. Amyloidosis has a fairly classical appearance on MRI scanning, and the coloured pictures that you see represent an even newer technique that we can actually quantify how much amyloid is in the heart. The real danger has actually been the use of bone scintigraphy. This came into clinical practice about 10 years ago, and over the last 5 years has been much more widely available and is available again in several centres in Scotland. Nuclear imaging is quite a commonly performed procedure, and a simple bone tracer and a simple grading system allows us to compare uptake of this within the heart and the bones. And this allows us to grade the amount of cardiac amyloidosis present. Now, this has been really useful for trialing treatments and for monitoring disease. There's some interesting work being done in Edinburgh using PET imaging, which again is looking at trying to understand the heart muscle in more detail. So now we've got a very clear pathway and way to diagnose cardiac amyloidosis that avoids the need for a heart biopsy. I won't go through the details of this, but this has been a really fundamental change to the way that we diagnose and manage amyloidosis. So I hope that in the future, we're going to be much faster at diagnosing it, and the process is going to be less invasive for patients. Once we've made that diagnosis of amyloidosis, we then come down to understanding whether it's a hereditary or a non-hereditary form of transthyretin amyloidosis. In Scotland, we're fortunate that we have a fairly well-developed genetics service and have genetic testing quite easily accessible. A lot of our families are living in Scotland, communicate with each other, and it's relatively straightforward to offer what we call cascade testing to relatives. So I think in Scotland, we can talk a little more during the discussion. I know there's work to do in terms of education and increasing awareness about amyloidosis. And I'm sure some of you will be frustrated at how long it's taken to get to your diagnosis. Everybody, regardless of where they live, should have access to specialist care, and that includes all the fancy imaging tests and genetics that I've talked about. And we hope that treatment and patient support is also going to be very much part of that for everybody. So I thought on the eve of the Scottish election, thank you for listening to me instead of the news. And I think it's really important that we come together as a group, patients, clinicians, and work together nationally and with the National Amyloidosis Centre in London to improve care for patients in Scotland. Thank you for listening.